All right, final session of the day. And then we have a reception next door. So we're excited for our panelists. We're going to be focusing on the social service elements of maybe CCP programs, other care continuity models. So you'll hear a range of different models and experiences in implementing and taking the lens that we've been applying to the rest of the sessions and discussions and to thinking about social service provision within these teams. So with that, I will turn it over to our first speaker, Nicole Gear.
Hi, good afternoon, everybody. My name is Nicole Gear. I'm a clinical social worker. I work within the comprehensive care program. I've worked with the CCP team for 10 years and in kind of various roles. I started out when we had one social worker in the clinic. And then as our team grew, kind of became a social work manager and then now work in a program advising capacity while I still do some clinical work and have a behavioral health panel of folks that I follow, along with working very closely with our social service team. So today I wanted to talk a little bit about how we thought of the foundations, what questions we asked when we were building our team. I think many of you have seen this slide with David when David's talked about the program, but so we have our core program, CCP, the continuity of care in the clinic and the hospital. In this program, we also have a social work team that follows folks as well. And then in the C4P arm, that's where we add in the systematic screening for unmet social needs, the access to community health work, and a community arts and social program. And so when we were building out this third arm of the program, we were thinking about 30% of patients that have been enrolled in this kind of core model of CCP, they weren't engaging. And so I think the hypothesis was that there was a whole host of needs that were unmet that could somehow be preventing people from engaging. So we went about the work of, screening for those needs and then building a more robust team to address those. So back in 2018, we started out with a theory of change model, and we walked through this as a team, just thinking about, what are some of the assumptions we wanted to work from, kind of ways we wanted to organize our behavior, how do we want to approach patients, what were strategies that we could employ from both social work frameworks and others, what are some of the influential factors that are happening for the folks that we're serving, and then we took a look at barriers, assets, and what impact did we want to have. And so I won't go through this slide in general, but this was a useful kind of high-level look at how we wanted to design the foundations of our team. And here's the kind of core model here. We have 3.5 social workers, and so we have a social work manager, we have 2 social workers, and then 1 part-time social worker who that's me, and I can also, I've been trained to do some psychotherapy. So there's kind of 3.5 of us sitting at the core of the model. We have 1 community health worker who is able to see patients in the home and assesses and intervenes on the 17 areas of social needs screening that we do, and also works closely in conjunction with the social work team. Just a quick look at our panel. So think of 1 comprehensive care physician, sees about 200 patients. Our social workers, our LCSWs, have either 2 physician panels or 3, so anywhere from 400 to 600 patients. Our social work manager follows our home care panel, which is about 40 patients. We also have social work interns that rotate with us, and I think this is an interesting consideration point of like how you can partner with your local landscape of graduate programs or other training programs. It's really allowed us over the years to scale up like important, I would say, modifications or adaptations that have been useful in our program. So we do a number of like groups and behavioral therapy options that I think access to social work interns has been a really nice pathway to explore. So just encourage folks to think about that, where they can kind of tap into their local professional training programs. And then we also have an AmeriCorps program that we embed members into our team, and the AmeriCorps folks help us do various pilot projects, including a really cool housing pilot, financial wellness initiatives, among others. Here's a look at our team. My amazing colleagues are up there, our AmeriCorps member, our current social work intern. My colleague Megan is there in the back. You'll see a quick glance at how we divide up by our physicians and how we tie to them. So we're paneled. And then just kind of a funnel of like, what are all the ways that we can get referred? What are all the things we're kind of looking at? So we're definitely doing social needs, concrete needs, care management, care navigation, doing some education, advocacy. We're doing a lot of behavioral health and emotional support. So these all can kind of funnel together to look at this big, busy eco map. But I think the really dynamic aspect of our work is that we have some scope and we also kind of have concentric circles here. And we talk a lot around these issues or these common things where it'd be like consult to social work for this one thing. There's multiple ways the community health worker might work on a housing project or housing issue. Then we might, how that might get kicked up to social work. And we have multiple meetings that we have even as a social work team that kind of mimic like multidisciplinary rounds. And I'll talk a little bit about that, where we can dig more into the nuance of it's not just your job as the community health worker to do housing. Like we all are thinking about this from kind of the various levels of our training and backgrounds. So many of us have come from child welfare, someone has the therapy background. So we can really kind of think of this like a team of specialists. So some other really like key foundational things to our success as a social service team that encourage sites to think about is standardizing workflows, thinking about how you onboard and train folks. What are the values? What are the ways that you want folks to approach care? And I'll talk a little bit about some of the frameworks we use. We make commitments to one another. We make commitments for ongoing how we're going to talk about patients. And I think those have been important if I'm thinking about some of the PPP implementation work we've done. Like, why as a provider, as a clinician, would I continue to do this work for 10 years? Thinking about, my role, how can I continue to maintain motivation to do this work? What's my scope of practice? Having that regular team communication, not feeling like I'm the only one navigating with a difficult case. We have pretty regular opportunities for support, supervision, feedback, and not only towards licensure and like professional development, but continuing education, support to try new things, try new pilots. So I think that's been key for our team. And then the integration, sharing systems, being all on the same EHR, intentional workflows that allow us to work with other disciplines on our team. And then the co-location, I can't, we talked a lot about space, but I can't highlight more how that organic communication with the team all day long, just walking past each other, walking in the hall into the patient room, handing off, like that really is the richness to our relationships and our relationships with one another. We know each other really well, and we get to know our patients really well. And so there's really, this is a shared, these are our patients. It's not just your patient. So, putting my clinician hat on and my training in psychotherapy, I thought a lot about the work that we do and started pulling out some themes from some of the like therapy work that I do that often focuses on reflecting on long-term relationships. And there's some behavioral therapy frameworks that really highlight the distress that you can feel in a long-term relationship. I don't think that's unusual for any of us who are in long-term personal relationships. But these complex care models are about how do we preserve long-term relationships with people. And in long-term relationships, things are going to come up that are tricky. There's going to be difficult conversations. You're going to get distressed, dysregulated. You got to manage your emotions. You got to be working in this complex environment. So I got really curious about how can I embed some of the frameworks I'm learning to help patients build skills within the care team, within the medical model, and like do it in a way that's effective and sustainable and not, let's do this over lunch for like a wellness thing. Like, I think that's really hard, as many of us in medicine are often asked to do build our resilience outside of the day-to-day workflow. So CCR is what we call complex care rounds. It's a twice weekly care team meeting that the social service team initiated, but we invite all members of the care team to, our CCP, our physician colleagues, our nursing colleagues. They come in when they need to. We talk about care dilemmas. We support one another in our ongoing work. I'd love to talk to anyone more about it, but I'll just do the highlights here that built out of a behavioral therapy framework called dialectical behavioral therapy. Just kind of two things we're holding in the room at any given point, that we want to engage in problem solving. We want to help connect patients to get resources to live better, to figure out the various issues that they're facing. We also know we can't solve every problem, look at everyone as a problem. We also need to understand, how did it come to be this way? It makes perfect sense why you're struggling. So we work a lot with, like, how do we create change and help each team member think about, the change and the best care possible, while at the same time accepting and validating this experience, what you're feeling as the clinician. Even it can be difficult. The problems we're facing have so many components to them. So how do we maintain the motivation of the people on the care team to continue to provide this patient care over time? Some of our foundational consultation agreements, and these are things that we go over every week. We really try and make them living, breathing commitments of a stand that we take with our work and with ourselves. So a few just like questions that these help us pose. The first one, this both and stance, is whose perspective are we leaving out? Is the patient's perspective in the room? Is the hospital perspective in the room? Is our administrator's perspective in the room? Can we talk about it from various perspectives? Can we see all the different ways that this problem or this tension needs to be talked about? Know thyself is a question we ask ourselves around limits and what do I need to do my work well? And that usually leads to a lot of questions in long-term relationships and the care of a care team and with patients. What's the function is our commitment to really understand a problematic behavior, if we're defining it as that, or maybe a difficult patient encounter from a descriptive way versus a judgmental way. It's very common, like, this patient's non-compliant or non-adherent, and we work really hard in our complex care rounds to, what does that mean? How is that showing up? Why is that difficult? And why might it be? And why might that person be interacting with us that way? And I think it makes us more nimble and able to see from a different perspective, so we don't get stuck in our judgments in the same, kind of narratives that oftentimes disadvantaged patients are being. That's the narratives that limit access, I think, to more robust care. Last one, to err is human. Like, we're going to make mistakes. We want to have long-term relationships and we want to do this well. We have to be okay with making mistakes, or at least being able to talk about them, talk about where we're struggling, talk about relationships that are difficult within the team and with our patients. And we do this so that we don't have to defend ourselves from always being perfect and virtuous, and because we can learn to do better. These are 4. We have a couple others, but they have really, I think, for me, and I'll speak for myself, just really transformed the way I can continue to approach this work. And it makes it kind of an active process. We're not just a mission statement that we never talk about. We really apply this to patient encounters. We also kind of out of that developed a complex care triage. So in this meeting, after we look at our commitments, we'll bring cases. We're talking about cases. We're talking about the way we're going to address things next. And so we use this kind of ranking hierarchy that intentionally asks the clinician who's bringing the case to take a look at how is this impacting me? Do I need some other perspectives? Do I need someone to just lend some resources? I don't know how to get this person transportation. Or am I at like a 1? It's going to be really hard for me to go about my day unless I talk about this here. I don't know that I can continue to provide care because I don't know what to do next, or because I'm so frustrated, or because fill in the blank. And everyone that comes in presents, their need. Where are they falling at this? Is it a 1? Or, is this more just like, let's have a discussion? And we also rank the patient need. So it's this intentional focus both on the clinician, what's coming up for you, give some space to reflect, give some space for the team to validate, problem solve, provide skills, while also doing the work that we're there to do, which is to care for patients. And so this is also, I think, put in this idea that we're people too, and we're having these relationships. And so in a complex care, like we're thinking about staff turnover, how do we keep people doing this work? How do we keep them thinking about how this is impacting them? This is one way that we've tried to bring that piece in. And then I'll end here just talking about reimbursement. And I think this is so big. I wish I had, another hour to talk about this, because I think for me, it's been transformative in the way we as social workers, we as social service providers can continue to demonstrate how value to programs like this. And I think it's so hard. I mean, so many of my physician colleagues are here. David, I know people so believe in social work, and it's just always hard to find the money to pay for us. And I would argue we're relatively cheap for labor, although we, are a high value add. And so I think there's, a number of ways to think about your program, where you're situated, the type of payer mix that you have, and also the training of your social work team, what needs your patients have. Certainly when I started, there wasn't a lot of access for therapy or psychiatry support. And I was seeing patients who really needed to have some long-term behavioral support or psychotherapy support. And so there's been some new billing models that have allowed us to pilot. Now we talk weekly with a psychiatrist, and we can do some pretty advanced behavioral care management. We can talk about some pretty novel psychiatric drugs. We've stabilized some of our most complex folks who were delusional, psychotic, living on the street. It has really transformed, I think, our confidence in being able to manage some really complex patients without saying, you don't come see us anymore, you have to go over here. And by knowing they're connecting with psychiatry, and we can check in, oh, you missed your appointment. Okay, you're not booted out of the clinic. We can advocate for you to get back in. And that, I think has been valuable, and we're getting paid for it too in primary care. So happy to talk to folks about, that adaptation if it feels relevant for the folks you're seeing. There's a whole host of new codes that the physician fee schedule has approved, broadly defined as the health equity code. So there's more billing and reimbursement available for social determinant of health screening, community health work, caregiver training, principal illness navigation. I think we're in various discussions with the institution about how to get that up and running. But you should know those exist. And I know I'm running out of time. I'll just flag the advanced primary care management. This is a new payment from Medicare that I think could be particularly important for complex care programs, but they kind of bundle a payment to primary care clinics for kind of all the supports provided outside of the routine fee-for-service care. You can still do fee-for-service, but I think could really help provide the case for expanding your social service team or expanding a team of supports for the physicians. I'll wrap there. Thank you.
Hi, everyone. I'm Therese Byrne. I'm a social worker at Rush University Medical Center, and I work on a team called Rush at Home. We do home-based primary care. So just a little bit about Rush. It's comprised of 4 different components: Rush University Medical Center, Rush Copley and Aurora, Rush Oak Park, and then Rush University. Rush at Home and our CCP program are based out of Rush University Medical Center, but we do take referrals from Rush Oak Park as well for Rush at Home. CCP right now is just within Rush University Medical Center. So Rush at Home is a home-based primary care program. All of our patients are homebound adults, ages 18 or older. We have a robust team of providers, doctors, nurse practitioner, nurse, social work, community health workers. And here's a picture of me visiting one of our patients in her home. So we serve over 350 active patients. We hit our ceiling right now is 400. That's about the limit we can take. We usually kind of float between 350 and 400. All of our patients have 2 or more chronic conditions and some social determinants of health needs as determined by a screen that's done by a community health worker. Right now, our age range, it says 30 to 102. I think we actually do have a patient who's 19, but 30 to 102 officially. And then you'll see our breakdown of race and ethnicity. Okay, so just some things a lot of you in this room hopefully know, but social work and community health work, we partner at Rush on our team, and a social worker has a master's degree, and you'll see listed the some of the interventions and skill sets that we have, and a lot of strong communication skills and problem solving, I would say, are like 2 of the primary things that I do in my work. And then the community health worker, they have a high school diploma or associate's degree, and then they also do 6 weeks of training in core competencies. And one main thing is that they live and work in the communities where they serve. So they're seen as experts in their communities, which has been really helpful with the Rush at Home model. Our community health worker lives on the west side, and in fact, like some of our patients are her neighbors, and that can be a little tricky sometimes for her. We've worked through some of that stuff together, but she's just an expert in ways that I could never touch. And then we do have some shared work overlap. A lot of what she does is providing some referrals and resources, and then I kind of get more involved when things get some more complex needs. Okay, so the comprehensive care model in Rush at Home. We have medically complex patients with Rush at Home. They are all homebound for a medical reason. And so this was a good program to pilot with the comprehensive care model. And then integrating social service, I think, is like a super important part of this model being successful. Stakeholders, you all are aware of all of those. And barriers, something that we talk about a lot on our team. Just there's never enough resources, miscommunication. I'll circle back to that in a minute. And then weekend discharge. That's something that I identify as a barrier. I work Monday through Friday, and we try hard to communicate with each other. But if someone's discharged like late Friday night or Saturday morning and I don't know about it, come Monday, sometimes I get calls, they don't have their antibiotics. Their DME didn't show up, their IV infusion isn't happening because their home health nurse didn't call. So things that just can be a little trickier for our complex patients. So one big thing that is super important with the Rush at Home and comprehensive care is the multidisciplinary teams being very committed on both ends. I'm speaking from the outpatient side. We have a team that is really strong, and it's been really wonderful to have this great communication with the inpatient team. We try to communicate from the very beginning with each other, and the providers and the case managers inpatient communicate with myself and the primary care physician. We are trying to measure some of the outcomes. We have just started, so to be determined, but looking at fewer hospitalizations and emergency room visits, and really an increased access to primary care, which is key with the Rush at Home population. And then the big thing is communicating early and often with the inpatient team from our perspective and talking about discharge needs. And that's when miscommunication I put that on the earlier slide, and I was like, I don't really know if this is the right word, but really it's just that what I've noticed anecdotally, and we've talked about within our Rush team, is that When I get busy, patients are still sort of scattered all over the hospital, not all on one unit, and I'm not like following up really closely with the inpatient team. Then frankly, that just leaves a lot more work for me when they get discharged, because then things have slipped through the cracks. And so that's just like miscommunication. Like, again, not realizing that someone's pharmacy that's listed is a mail order pharmacy, and that's not going to work for their pain medication, things like that. So just that's things that I try to notice before discharge and communicate to the inpatient team to make sure that they're on top of, and we have everything like tightly wrapped up before people get discharged. And then also lowering the costs, preventing rehospitalizations. The rush at home patients do have a high hospitalization rate because of all their medical issues. And with this comprehensive care program, we are trying to, keep people out of the hospital, at home, out of the emergency room, doing everything we can to provide their care at home. So tools, some of the things that have already been discussed, but, a lot of different assessments with social work and community health workers. The interdisciplinary team meetings are key for Rush at Home. We meet once a week, every Monday for an hour and a half. We discuss all the admissions and discharges from before. We go over complex patients, just some general stuff. And the inpatient team joins us when they can. And that's a good opportunity for the inpatient team to bring up concerns with any particular patient that they want the entire team to hear, not just like myself and the primary care provider. And then also just, constantly trying to address the barriers. Big barrier for us, which isn't going to be any surprise or different for all of you, I think, is transportation. We have this home-based team. It's amazing, but like specialists don't visit patients in their homes, and almost all of our patients need to see a specialist. And trying to get like someone who's bedbound, in an ambulance to an appointment, it is really complicated and can like take up half of my day. And so those are things just kind of like talking to the Rush at Home team, just to make sure that they understand like these are things that I'm going to work on from a social work perspective, but is not guaranteed to happen. And then also this again has been really amazing to partner with the inpatient teams to say like, this patient, you want her to come back in 4 days. I'm not sure that's going to happen because our insurance is not going to cover this transportation. Or just being able to say, like, we've been trying to get this test for like months and we can't get them in. Is there any way it can get done while they're inpatient? It has really helped. So next steps, we talk a lot about flexibility and creativity, which we have to do with Rush at Home. There's always things kind of being thrown at us that we have to try to navigate. And doing, again, the partnership with the comprehensive care team has been really great because it has allowed us to sort of bring more people in and get more ideas together to solve some problems for specific patients, maybe who are hospitalized a lot, and then just some general issues that we see come up for our patients in the hospital. The continued communication, we just talk all the time over Epic about what's going on with the patients. And then, we would always love to grow the program, Rush at Home and comprehensive care. Just thought of something that I'm forgetting. I want to say to you all, I'll think of it. But that is it. Just added some stuff here for resources and additional reading. And thank you all very much.
So my name is Michael. I am the serving medical director of the Vanderbilt team. So what I'm going to do with my time as the panelist here is I want to be transparent with workflows of work that I don't do. So I am a strong believer that the patients we take care of, my input really doesn't matter. It really is contingent on the work our social workers and case managers do. They're the ones who are advancing the care of the patients. We are primarily, we're like Rounder Plus. You know, we're mostly an inpatient hospitalist group that bleeds out into the outpatient setting. We do primary care, and we have some other services that we attend to in the clinic. But we're really focused on reducing the utilization while they're in the hospital, and we use that clinic as our resource to do that. What I want to do is deliver the workflows that our outpatient social worker, she's a licensed clinical social worker, does, and then our acute care inpatient social worker and acute care case manager. Like I said, we're a comprehensive care solution for the health system, and we're payer agnostic. So we take all comers, no matter what their payer mix is. We do have the reason why we do that is because, much like Madison, Wisconsin, we have a large geographic area that we're taking care of. It's very rare that any of our patients are within 10 miles of the health system. And the ones who do are usually having a PCP that they've had a long-term established relationship. So where we try to focus in is our enhanced communication practices. And it's really about setting a culture within all team members, having a shared mental model that is non-hierarchical based on what your background and training is. The physicians truly have the least important opinion in our patient's care. I do have a quote that I like that I'll start off with these patients. And for the high need, high cost, high utilizing patient population, it's a comprehensive care approach that is needed, that is interdisciplinary nature, utilizes an individualized care plan with a consistent care team to prevent fragmentation, address social determinants of health, and the functional needs of this vulnerable population. I think that's kind of a summary of what comprehensive care is and what they're doing to address the patient population. So I'm going to start off with the work that Christy, our outpatient social worker, does in terms of social determinants of health screening, primarily for our primary care cohort. We have about 55 in our primary care cohort right now. It was as high as 80, but due to the highly comorbid nature of this population, we've had several who have passed and just haven't been able to re-enroll patients in the primary care division of our group. So again, I'm just trying to be transparent in what Vanderbilt's workflow is. So Vanderbilt actually has this navigator of social determinants of health embedded within Epic, which is nice. So if it can be embedded in Vanderbilt's Epic, it can be embedded in anyone's Epic. I know they're not all equal, but the technology is there. And this lives within the social history part of the chart. So it's really easy to find. So semi-annually, for all patients who are enrolled in our primary care population, Christy is going through each one of these questions and domains one by one. I'm going to actually, if you click on each one of these, it takes you to some surveys that anyone can use. And I'll highlight a couple here, and some of them are not surprising, and some of them we as a group have really worked on addressing. So unsurprisingly, substance abuse can be endemic of this patient population, and you don't want to miss anything. And I think this is taught in basic medical school, but or whatever your background of training is, but this is what happens whenever you click on tobacco use or alcohol use. And it's very simple just to record it into the in Epic. And what's nice about this is it becomes a discrete data source, which is great because if you have a patient portal and patients who can use patient portals, you can actually turn this into a patient reported outcome measure that's delivered to the portal before a visit or while they're in the acute care setting. You just have to orchestrate it. And the technology is there to do it. They talk about financial resources or strains, transportation, stress, interpersonal safety, housing stability, food insecurity. I will take a moment to talk about transportation. Some work that we have done back in, I think it was 2021, one of my colleagues went to the Office of Health Equity, and they were calling out health equity grant RFAs, and she got one to develop a transportation grant for ride shares to help get our patients to outpatient appointments as an attempt to divert from emergency room and acute care presentations. We actually have found in Vanderbilt that a missed appointment is actually more expensive than transporting the patient, assuming that it's not ambulance ride. Anything else is cost effective. And the reason for that is not only does a patient, if they don't show, one, they're not there, and then someone else could have taken that spot, but then whenever you reschedule them, it's taking someone else's spot. So it really is eating into the provider productivity of the health system. And I think that's why it's key to think about these business models when you're developing ROI cases for any sort of intervention that you're doing. So what she found was that this was cost effective. It was a small grant, $10,000, but it lasted us for about 1.5 years to transport patients to clinic appointments. What we found is that rideshare with Uber and Lyft was actually not reliable. If you're not there within 3 minutes, they're going to leave. You have to schedule a new one. Then they're late for the appointment. And we actually found that the Music City taxi was a more effective resource for us. And over time, we were able to turn that grant into a fund given to us by our Division of Internal Medicine, which now we can actually build into the budget of our clinic. And that's been approved by our health administration that is part of our budget, just because we've shown the effectiveness over time. So even a small grant, $10,000, can turn into something that is a resource for your patients. We have been able to, because now we're actually liable for the resources of it, we do look at what are all the resources in the community, and there's Access Ride with the busing system in Nashville. In addition, that we've been trying to use. And then in Tennessee, our Medicaid does have transportation benefits. I'm not sure if that's universal to every state, but it is in Tennessee. I don't remember that being a thing when I was in Pennsylvania. This is calling for a software update.
Would you want it?
All right, cool. These are just some other ones, part of that screening tool. Food insecurity, physical activity, are the utilities at risk for being shut off? All things that impact the patient's health. I am going to touch more on this social connectedness and the idea of loneliness, because we did have an intervention that we have enacted in our program. So that is the social determinants of health screening that is available in Vanderbilt's Epic. And like I said, this is easily translatable. I will say, aside from one other clinic that is an outreach clinic, we're the only other clinic that is using this regularly. 2 minutes left, better keep going. Okay. So next, moving on is what our acute care social worker does on her assessments. It's a lot of the same things, but I wanted to provide you guys a script of what she does whenever she's seeing patients in the hospital and the text she uses to document it. So it's regularly used for us across hospitalizations. And I won't go into this. I assume everyone's getting slides after they leave here. Next one is what our nurse case manager in the inpatient setting. Some of the screenings she does every hospitalization. It's in Epic, and if it's in Vanderbilt's Epic, it should be translatable. So really, this is just for you guys to look at your own time, but it does include a readmission score. What is the insurance of the patient? Where did they come from? How far away they are from Vanderbilt? Who's their primary caregivers? All information you need to appropriately care for the patients. Like I said, if you don't know this information, it doesn't matter what kind of antibiotic I'm going to give them, or if I'm going to give them a PICC line to do long-term antibiotics at home if it's not a feasible outcome to intervene upon. All right, so what I did want to talk about is how we addressed loneliness in our population. So we were granted a grant through the Center of Healthy Aging Behaviors and Longitudinal Investigations here at the University of Chicago. And what we tried to do is implement a feasibility study to show that if we could bring patients together for a clinic afternoon, 8 patients, and instead of doing 30-minute appointments throughout the afternoon, bring them all here at the same time. And we're going to put them all in a room and we're going to do the medical visit together. But we're also going to provide an education session given by either an outside speaker or one of our nurses. And then we're going to have a group therapy session at the end. It's about 2.5 hour long visit. So you can see the benefits if you're doing time-based billing for practitioners and how this becomes a financially feasible model. This is our curriculum. So during the grant, we did 3 sessions throughout the year. And this is kind of outside the scope of this talk, what the results are. But the patients who attended wanted this to continue. They said, please do this. We love this. This is our source of community. Whether or not it had a statistical impact on loneliness and social isolation didn't matter to at least the 8 people who were currently coming. It was high valuable for them. And we were knocking out 8 appointments in an afternoon, which is pretty good for our clinic. This was the curriculum we did the last year. So the first one was actually introducing the patients to all the practitioners. We're not cohorted provider to like 200 patients. We have a panel of about 800 patients and we all share them. And so it's a lot of extra over communication between all team members, but for all the physicians, we are responsible for all patients together. So we wanted to make sure that all the patients knew who we were in the first visit, and you can read kind of everything we did. But my favorite one was helping patients develop their own personal healthcare summary so that if for some reason they came in contact with a healthcare provider outside of the ICP, urgent care, in the emergency room, they could reliably tell that practitioner what their medical history is. I have one girl, she's 28, and I kid you not, has 32 actual diagnoses that I manage. And it's hard for her to communicate that.